Hello everyone. Today cover important definitions in nephrotic syndrome. The most of the definitions I have covered in the last video. Today we'll cover few of the new definitions that they have been updated in IAP. Okay. First is complicated relapse. So what is complicated relapse? So relapse associated with the life-threatening conditions. So relapse associated with life-threatening conditions such as first one is hypovolemia requiring inpatient treatment. Hypovolemia requiring inpatient care. Second, severe infections in the patient has relapse along with severe infections such as peritonitis, cellulitis and meningitis. Third, relapse associated with thrombosis. Okay, so the relapse associated with any one of these life-threatening condition is termed as complicated relapse. This is your first definition. Next one, significant steroid toxicity. So when will we have send the patient with the steroid treatment, that is treatment of the first episode will be prednisolone at the dose of 2 mg per kg per day for about 6 weeks will be your treatment. I will tell you in detail. So that will be your treatment for your first episode. So what are you going to monitor in that patient? Okay, so to rule out their steroid toxicity. And when will you call the child has a significant steroid toxicity? So you will be monitoring their glucose. So if the child has a hyperglycemia with the fasting glucose, this fasting blood glucose or blood sugar of more than 100 mg per deciliter or postprandial blood sugar of more than 140 milligram per deciliter, or when the HbA1c is more than 5.7%. You call it as hyperglycemia in the patient undergoing steroid treatment. Next is obesity. That is when the child's BMI is more than equivalent of 27 kilogram per meter square in adults. You call it as obesity. Next is short stature. So you have to monitor the weight, height and glucose. So short stature you define as height. It is less than -2 standard deviation for age, or height velocity is less than -3 standard deviation for age. So height for age or height velocity for age. Fourth is raised intraocular pressure. Next is cataract. Fifth one is myopathy. Sixth is osteonecrosis. Seventh is psychosis. So if the child presents with a hyperglycemia, obesity, short stature, with complications in the ocular region, with myopathy, osteonecrosis and psychosis, you call that the child is having a significant steroid toxicity. Okay. The next definition here we'll see is difficult to treat steroid sensitive disease. Difficult to treat steroid sensitive nephrotic syndrome. So when you call it as difficult to treat, when both of the following is present. Okay. When both of the following is present. That is when the child has a frequent relapse or significant steroid toxicity with infrequent relapse. With significant steroid toxicity with infrequent relapse. Second, when the child has failure of more than or equal to 2 steroid sparing agent. So failure of more than or equal to 2 steroid sparing agents. So what are the steroid sparing agents here we talk are including levamisole, cyclophosphamide, mycophenolate mofetil. So when the child does not respond to more than or equal to 2 of these following, we call the child as having a difficult to treat steroid sensitive nephrotic syndrome. So these are the new definitions that has been included in your IAP recommendations. Next we'll see about therapy for first episode of nephrotic syndrome. So therapy for first episode nephrotic syndrome. So that is, you start the child with tablet prednisolone at the dose of 60 mg per meter square per day or 2 mg per kg per day. Maximum it is 60 mg. You can give this in 1 to 2 divided doses for 6 weeks. Which one do you prefer? Whether in body surface area or in body weight. So body surface area is mostly preferred. Why? Because when you give the child dose in body weight, the dose will be an underdosing. So the child can have a frequent relapse if you have given it body weight. So most preferred is this body surface area, that is 60 mg per meter square per day. You have to start prednisolone with this dose for 1 to 2 divided doses for about 6 weeks. Then it is 40 mg per meter square per day. It is a single morning dose. On alternate days. This is also for 6 weeks. So everything you give this for 6 weeks, not 4 weeks or 4 to 6 weeks or less than 4 weeks. It's everything is 6 weeks. It is 60 mg per meter square per day starting with this dose for 6 weeks, then 40 mg meter square per day on alternate days for 6 weeks. This is the therapy for first episode of nephrotic syndrome. So prednisolone is best given following food. Therapy with antacids or Rantac is not routinely required in patients with the first episode of nephrotic syndrome. What is the treatment for frequent relapse? Next is treatment for frequent relapse. So frequently relapsing or steroid dependent nephrotic syndrome. So we have seen the definition of frequent relapse and steroid dependent nephrotic syndrome in our previous video. So when the child is frequently relapsing or a steroid dependent nephrotic syndrome, then you start this child with a prednisolone, tablet prednisolone on alternate days at the dose of 0.5 to 0.7 mg per day. Then if the child has a stable remission with this dose, then you can reduce the dose to 0.2 to 0.3 mg per kg for about 6 to 12 months. Okay. Next, if the child has a minor infection during the treatment, if the child has minor infection during the treatment or with the steroid, whether you have to stop the steroid or not. You should not stop the steroid. You should give daily therapy. Instead of alternate day, you have to give a daily therapy. Okay, you have to give a daily therapy at the same dose, that is 0.5 to 0.7 mg per day. Same dose for about 5 to 7 days. So it is a daily therapy and not on alternate day therapy when the child has a minor infection. Okay. Next is, if the child is, or even with these dose, the child is not getting remission, or the child is frequently relapsing, or the child is having a steroid toxicity, then what you do? Then, even with that dose, the child is frequently relapsing or the child is having the steroid toxicity. The steroid toxicity I have told in the previous slide. Or if the child is having a steroid threshold of more than 1 mg per kg on alternate days, or more than one complicated relapse. Complicated relapse is the whether the is when the child presents the relapse with hypolemia or the severe infection, or with the what is the other one I have told you, thrombosis. So if the child has more than one complicated relapse or with a significant steroid toxicity, next what you do? If the child has these features, okay, these three features, if this is yes, then you start the child with the mycophenolate mofetil or cyclophosphamide, or no. If the child doesn't have these three features, if the child have a steroid threshold of only 0.7 mg per kg on alternate days, or considering the patient's age, patient's toxicity and everything, you should decide the treatment, whether it is low dose steroid sparing agent or a high dose steroid sparing agent. So the low dose steroid sparing agent can be low dose of mycophenolate mofetil or levamisole. Even on the child is on low dose mycophenolate mofetil or levamisole, the child is having a frequent relapse, then you will go for mycophenolate mofetil with cyclophosphamide. Okay, next, if the child is difficult to treat steroid sensitive nephrotic syndrome. So difficult to treat steroid sensitive nephrotic syndrome is the child is not responding to more than or equal to 2 steroid sparing agents, that is mycophenolate mofetil, cyclophosphamide or levamisole. Then what drugs you use? Next choice of drugs are cyclosporin, tacrolimus and rituximab. Okay, this is the treatment flow chart for the child with the frequent relapse or steroid dependent nephrotic syndrome. So okay, we have seen the treatment for first episode and frequently relapsing child. Then I have to cover another one more question here, that is always asking question, that is indications for renal biopsy. This is a favorite questions of all the examiner, that is indication of renal biopsy. So you will be telling first indication, you will tell us less than one, onset of nephrotic syndrome less than 1 year, more than 12 years. So but onset less than, in children with the onset less than 1 year, that is infantile nephrotic syndrome or congenital nephrotic syndrome, you have to do a genetic analysis, is the first choice of investigation, and it is not the renal biopsy. So you have to do genetic testing for this child and not renal biopsy. Okay, this one you have to make clear. Next, but when the onset is more than 12 years, it is renal biopsy. Next, when the child presents with hypertension, persistent microscopic hematuria or gross hematuria, or when the child has steroid resistant nephrotic syndrome, or the child presents with the systemic features such as rash, fever, arthralgia, low complement factors. Okay, low complement factor, that is mainly C3. Or when the child is on prolonged therapy with calcineurin inhibitors, or when the child is with prolonged therapy with calcineurin inhibitors and prior to use of calcineurin inhibitors. Okay, these are the indications for renal biopsy. In renal biopsy, what will they see? So in renal biopsy, what they are being subjected to? So they are being subjected to light microscopy and immunofluorescence. So it is recommended for this light microscopy and immunofluorescence. These both are recommended on all the kidney biopsy. These are recommended on all the kidney biopsies. Next will be electron microscopy. So this electron microscopy is recommended only for patient with gross hematuria or persistent microscopic hematuria, next is low complement, third is suspected disorders of glomerular basement membrane, suspected disorders of glomerular basement membrane. Okay, this is about the renal biopsy. So we have seen the treatment of first episode, frequent relapse, and the indications for renal biopsy. In renal biopsy, what we are going to look for. Okay, so this is, I have covered most of the questions from nephrotic syndrome, or if you have any doubts in the nephrotic syndrome, I will share you the PDF that I have been prepared. The PDF I will share, the PDF I will share it to you in the Telegram group. So the Telegram group will be PEATS University Examination Discussion Group. I'll share the link of this group in the description box. Okay. Kindly like, share, comment and subscribe our YouTube channel. Let's all learn pediatrics.